All right, thank you everyone so much. I'm Kirsten Fiest. I'm the Scientific Director of the O'Brien Institute for Public Health, and I'm so pleased to see so many of you here today, including our members, partners, colleagues, and guests for the 2025 O'Brien Institute Fall Members Forum. So this annual gathering is one of my favorite events of the year. It's our time to come together as a community, to share ideas, and to celebrate the work that the Institute and its partners are doing. We're really, really excited to see you all here today. I'd like to start our event off in a good way by acknowledging that the University of Calgary is both the current and traditional territories of the people of Treaty 7, which includes the Blackfoot Confederacy, which is comprised of the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bears Paw, and Goodstoney First Nations. The City of Calgary is also home to the Métis Nation within Alberta, Nose Hill Métis District 5, and Elbow Métis District 6. So this is a picture up on the screen of a place that I like to walk with my family. It's at the top of the stairs at the McHugh Bluff. Don't get me wrong, I do not run up these stairs. Like many of you might be thinking, I like to walk here with my family. My husband does the running. But it's a place that I really feel connected to our city. As a settler on this land, I do recognize that acknowledgement must be accompanied by action. And in my own life, this means teaching my children about the true history of this country, including the legacy of residential schools and the ongoing impact of colonization that continues to affect Indigenous communities to this day. It means raising them to understand that reconciliation is not just a moment in time, but an ongoing commitment that we must all carry. And part of this education involves confronting some uncomfortable truths. Even now, many Indigenous communities in Canada lack access to clean drinking water, a basic human right that most of us take for granted. This reality stands as a stark reminder of how much work remains to be done and why our commitment to truth, reconciliation, and justice must extend beyond words and into action. So our theme for today, Women's Health is Public Health, reflects a truth that has too often been overlooked. Women's health is not a niche issue or a special topic. It's central to the health of our communities, our systems, and our society as a whole. Through the Sex, Gender, and Women's Health Research Hub, the O'Brien Institute is helping to close long-standing gaps in research and policy. The hub was created to bring together researchers, clinicians, trainees across the University of Calgary and beyond to make sure women's health is integrated into everything that we do. This work matters. For too long, women's health has been underfunded, misunderstood, and narrowly defined. The consequences of that show up in delayed diagnoses, inequities in access to care, and policies that don't reflect women's lived experiences. But thanks to the leadership of the people in this room and the new momentum and investment in this area, that's beginning to change. Today's forum is about showcasing that progress and the innovative research happening here at the University of Calgary. It's also about building new connections with the broader community. You'll hear from a wide range of voices today, including researchers, practitioners, and community leaders, all helping us rethink how women's health can be understood and supported through a public health lens. It's a powerful lineup, and I want to thank everyone who contributed to making this event possible, including the planning committee, the speakers, and the O'Brien Institute team. They'll make everything run very smoothly today, in spite of my technological issues. We had tremendous interest in today's event, and it's wonderful to see so many of you here. But because of our large audience size, we may not be able to get to every question during the Q&A periods. We'll do our best to address as many as we can. At all your tables, you'll find a brief handout explaining how to access Slido, which is the platform that we're going to use today to collect audience questions. Please feel free to enter your questions at any time throughout the day, and we'll be drawing on Slido and those questions that you input during all of the Q&A sessions. Thinking about accessibility, I would like to invite each of you to use this space however you feel most comfortable. So if at any point you need to sit, stand, stretch, move around, knit, doodle, please feel free to do so. I'm so thrilled to see some women here with their babies, Crying is accepted. Crying from the babies, crying from you, crying from anyone. Don't worry. I'll be sneaking off to the back to pump. There's lots of us here who understand what it's like to be a working mother trying to get this all together. I'm also so thrilled to see some pops of red in the audience today, and really, I know that this morning was maybe a bit different for some of you getting your kids out the door. But to begin the day, I'm so thrilled to introduce our first speaker, Dr. Erin Brennand, who's a professor and head of the Department of Obstetrics and Gynecology in the Cummings School of Medicine and the director of the Institute's Sex, Gender, and Women's Health Research Hub. Erin will open our program with the state of female reproductive health in Canada, gaps, gains, and a path forward, providing a panoramic view of the landscape from disparities in reproductive health to underfunding of research and care to opportunities for national benchmarking and coordinated investment. Please join me in welcoming Dr. Erin Brennand.
Okay, I need to advance this slide. Back to the agenda, okay? Good morning, everyone. Thank you for joining us for this year's Fall Forum. I'm especially pleased and excited that this year's theme places female reproductive health at the center of public health, not on the margins, not as an afterthought, but as foundational to the health of individuals, families, and communities. 3 years ago, I'm incredibly grateful that the O'Brien Institute supported a CIHR application that allowed us to establish female and women's reproductive health as a research and knowledge mobilization priority within the Institute. Since then, through the Hub, we have undertaken studies addressing both Alberta-specific questions and issues of national importance. Together, the Institute and the Hub have convened public dialogues, informed policy conversations, and this spring will host an Alberta-based clinical education conference to strengthen primary care providers' capacity to care for women in midlife, an area where evidence and research-informed support has often been scarce. Looking around this room, I see researchers, clinicians, policy leaders, and advocates, people who have dedicated their lives and themselves to improving the experiences of women and girls. Your presence is a reminder that progress does not come from isolated grants or single initiatives. It comes from a shared willingness to confront uncomfortable truths, to challenge inertia, and to imagine what better looks like. So as we begin today, let me ask, how are we doing in Canada when it comes to female reproductive health? What are the gaps that continue to undermine health and equity? What are the gains we can build on? And what will it take, structurally, politically, and collectively, to chart a better path forward? Because when we look closely at the data, when we listen to women, one thing becomes unmistakably clear. For all our progress, Canada has far to go before female reproductive health receives the attention, investment, and system-wide prioritization that it requires. So let's start by confronting the gaps, the uncomfortable truths behind our self-image as a country that values universal health care and equity. According to the 2023 Hologic Global Women's Health Index, Canada ranks 10th out of 11 high-income countries for women's health. For a nation with universal health care, this ranking should be a wake-up call. Where are we falling short? Our infant mortality rates remain higher than many peer OECD countries. Women of reproductive age are among the most likely in the developed world to live with 2 or more chronic conditions, making Canadian patients some of the sickest pregnant patients compared to our peers. Wait times for gynecologic surgery are among the longest in high-income countries. Unlike hips, knees, or cataracts, gynecologic procedures are not benchmarked nationally. As someone involved in healthcare administration, I can tell you this: what we measure is what we prioritize, and what we prioritize is what we resource. In recent weeks, the national spotlight has turned to a growing crisis in maternity care. Closures of rural and remote maternity wards have been occurring in Canada since the 1990s. But now regional centres, once thought untouchable, are feeling the strain. The situation in Kamloops, where every single OBGYN resigned simultaneously due to long-standing underfunding and safety concerns, is a stark illustration of what happens when systemic neglect reaches a tipping point. As a result of health system funding policies, for years, Canadian women have been traveling hundreds of kilometers to give birth, sometimes while in labor, often in treacherous winter conditions, and often without the support needed to care for their children at home. This is what a medical desert looks like. Not a sudden collapse, but a slow erosion of essential local care. And maternity care is just the beginning. In Canada, access to contraception depends less on medical need than on where you live. What you are offered is often limited by the training, comfort, and sometimes the values of the provider you happen to see. Medication abortion, while expanding access, still faces meaningful barriers where providers or pharmacies are unprepared or unwilling to prescribe or dispense. Common reproductive issues like PCOS, endometriosis, pelvic pain, prolapse, infertility, and menopause remain underdiagnosed, undertreated, and dismissed. Women often wait months or years for diagnosis. They travel long distances for specialty care and are far too often told that their symptoms are normal. And when we examine women's lived experiences, these structural gaps become personal. The most recent Canadian social survey, conducted by Statistics Canada, reveals that women are 5 times more likely than men to discuss contraception with their primary care provider. Even in 2025, family planning is framed as a woman's responsibility. Yet fewer than 1 in 5 women report substantive discussions about sexuality or sexual well-being with a clinician during their routine visits. Menopause, a universal female life stage, is similarly neglected. The Canadian Menopause Foundation's research demonstrates that 50% of Canadian women report that menopause remains a taboo topic for discussion, half feel unprepared for the transition, and 40% report isolation, shame, or distress while going through it. 72% of Canadian women say the menopause care they received was unhelpful, most often because their symptoms were minimized or dismissed. Reproductive health cannot be separated from the realities of sexual and intimate partner violence. Rates of violence against women in Canada has risen since 2018. 1 in 4 Canadian women will experience sexual or physical violence from an intimate partner in her lifetime, more than 4 times the prevalence among men. Indigenous women, racialized women, newcomers, women living with disabilities, and those facing economic vulnerability are disproportionately affected. Violence, coercion, and control intersect with reproductive health across the lifespan. In women's sexual decision-making, their contraceptive autonomy, pregnancy, miscarriage, abortion, birth, postpartum care, and our aging. These are not peripheral concerns. They are central to women's lived experience of reproductive health in Canada. Some frame these problems as problems of access, but access presumes the system itself is adequate, just unequally distributed. So I would suggest something different. This is a systems design flaw. This is about what and whom the system is designed to take seriously. Canada has built a health system that is excellent at responding to emergencies, but struggles profoundly with the chronic, complex, and deeply gendered conditions that define much of female reproductive health across our lifespans. These inequities that we see in care are mirrored, almost perfectly, in our research ecosystem. Today, less than 8% of the Canadian Institutes of Health research grants that fund research in Canada are specific to female health. 8%. And within that narrow slice, the majority of funding goes towards breast cancer, an area of undeniable importance, but it means that the rest of reproductive health remains chronically, persistently underfunded. And here in Alberta, the picture is even more stark. Recent reports show that only 3.4% of research funding flowing through this province supports women's specific health. There was a brief surge of investment after the 2020 federal budget announcement, a single one-time increase that many of us hoped signaled meaningful change. That funding is part of what allowed the O'Brien Institute to build the Sex, Gender, and Women's Health Research Hub. But to date, there has been no commitment from the federal government to renew this funding stream. Without sustained investment, research and development for female reproductive health in Canada will remain neglected. And in this landscape, conditions like endometriosis, pelvic pain, prolapse, menopause, infertility, and sexual health, the conditions that shape daily functioning, relationships, employment, and well-being, continue to receive only a fraction of the research, resources, and innovation they deserve. And yet, as a practicing gynecologist, I can tell you, these are the conditions that fill our waiting room. These are the issues that women whisper quietly about at dinner parties, Google at 2 a.m., wonder if they should just live with, or if it's all in their heads, and that they navigate, often alone, because the system hasn't kept up. In the 2 decades since I began my medical training, I have watched with awe how therapeutic innovation has accelerated in cardiology, rheumatology, neurology, fueled by sustained research investment and cross-sector collaboration. However, during that same time, we have not developed a reliable screening test for ovarian cancer, a disease which aggressively and painfully ends women's lives. Non-invasive diagnostics for endometriosis, which causes pain, infertility, and strips reproductive aged women of their ability to participate in school and work. Or really any meaningfully new class of therapeutics for many core gynecologic conditions, such as fibroids or PCOS. This is not because female biology is uniquely unsolvable. It is because as a society, we have not invested in solving it. To catch up to the average level of research investment seen in other areas of medicine, we would need a 15-fold increase in funding for women's health research. 15. And to reach parity with fields like cardiology, stroke, and oncology, the increase would need to be far greater. And let's consider again the prevalence of common female reproductive health issues. Endometriosis affects 1 in 10, PCOS affects 1 in 5, pelvic floor disorders affect 1 in 2, peaking around perimenopause and menopause. And perimenopause and menopause will affect every woman who lives long enough to see her late 40s and 50s. These are population-level conditions, but the research investment does not reflect that reality. Across North America, research focused on male-specific or male-predominant conditions is nearly 3 times more likely to receive funding than anything centered on women's health. This disparity means that women's health continues to receive less investment, we experience fewer discoveries and slower progress. And we need to call it what it is. This is not a small equity issue. This is gender-based neglect, both in government research policy and in industry investment. It's a harm that occurs not through action, but through persistent omission. It's a form of structural injury to half of our population. And because it is structural, it will not change on its own. Repairing structural gaps requires clarity about the levers of power. Responsibility in Canada is shared, often fragmented, across federal, provincial, municipal, and employer systems. Federally, Parliament and Health Canada set national policy environments. They regulate drugs and devices, oversee safety surveillance systems, and influence provincial budgets through the Canada Health Transfer. The federal budget shapes the priorities of research agencies, setting tone for what knowledge is generated and what is left in the shadows. These levers matter for female reproductive health because they determine the pipeline of innovation, the evidence base for care, and the regulatory frameworks affecting everything from contraception access to surgical device safety. When the federal government prioritizes women's health in research and regulation, provinces can build upon that foundation. When it does not, the downstream effects are vast. Provinces and territories carry primary responsibility for delivering care. They determine what is deemed medically necessary, what drugs are covered under public insurance programs. They fund hospitals, pay healthcare professionals, and decide which services exist locally. This explains why Canadian women's access to contraception, abortion, fertility treatment, menopause support, or pelvic floor care varies dramatically across provinces. These are policy choices, not chance. Municipalities translate provincial politics into our everyday realities. Free menstrual products in public washrooms, and Vancouver's City for All Women strategy shows the potential for cities to address social determinants of health and gender equity. Calgary, while adopting a broader gender equity, diversity, and inclusion framework, still lacks a precise, woman-focused strategy that acknowledges the unique gaps created by our city's history and industrial culture. And employers, too, influence our reproductive health. Extended benefits, drug coverage, pelvic floor physiotherapy, sexual therapy, and menopause support are often employer-determined. Workplaces act as de facto healthcare payers, influencing our health, workforce participation, and economic equity. Despite these gaps, there is reason for optimism. Public support in Canada for reproductive health and rights is strong. Nearly 79% of Canadians believe sexual and reproductive health should be a national priority. Policy innovation, while uneven, is happening. British Columbia introduced universal prescription contraception coverage. Some provinces are providing at-home HPV testing instead of traditional pap smears. Others are ramping up to provide universal coverage of menopause hormone therapy. Researchers in this room today continue to push boundaries, often pushing past the limited funding available to do this work. And grassroots advocacy networks for endometriosis, prolapse, menopause, and pregnancy loss have transformed silence into solidarity. And as we see through today's event, women's health is increasingly recognized as a cornerstone of public health. So where do we go from here? To me, 3 imperatives stand out. First, we must expand access to care and invest in women's health research. Advocacy is critical at every level: federal, provincial, municipal, and workplace. The federal women's health funding must be sustained and expanded rather than treated as a one-time gesture. Provinces must prioritize infrastructure for female reproductive health. This means proper resources for labor and delivery units and surgical capacity for gynecologic procedures, as well as planning for the healthcare workforce that females need. We must grow these resources, not stagnate them as our population grows. Municipalities must invest in women's safety, community supports, and spaces for learning and connection. And employers must recognize reproductive health transitions and the supports needed for women to thrive. Second, we cannot fix what we refuse to measure. We need to strengthen data collection and benchmarking in this country. Female-specific data must be collected, reported, and publicly accessible. It should not be buried in red tape, not siloed, and not politically interpreted. Because empowerment looks like evidence. It looks like researchers, like me and many of you, being able to analyze data and return it to our communities so that women in this province know where the gaps are and have the information to advocate for themselves. When women have data, we have power. And when women have power, systems change. Third, we must protect and defend sexual and reproductive health across the lifespan. This goes far beyond pregnancy and contraception care. This includes timely diagnosis and treatment for all of the conditions I keep mentioning: endometriosis, pelvic pain, prolapse, fibroids, infertility, and menopause, just to name a few. It also means confronting the tidal wave of misinformation that is targeting women, especially young women, at a moment when we are finally gaining the language and legitimacy around our bodies. During the planning of this event, one of our team members said something that stayed with me. Misinformation has become a form of violence against women. I believe that is true. After centuries of silence, to have knowledge distorted or denied now is not simply careless, it is harmful. But this roadmap to a better future cannot be written by one person or one initiative. We need the collective intelligence in this room. So on your tables, you'll find materials for our interactive noon session. We want your ideas, your lived experience, your priorities. The O'Brien Institute for Public Health will be compiling these into a shared statement of direction, a community-informed agenda for advocacy brought to policymakers at multiple levels. And as we begin today's program, I want to be clear. Canada's story is not one of failure. It is one of unfinished work. We have the expertise, public support, and moral imperative. What we need now is coordinated action. Imagine a Canada where access to female reproductive health care does not depend on your postal code, where menopause is treated as a legitimate health transition, where endometriosis, PCOS, pelvic floor disorders, and gynecologic cancers receive research intensity equal to heart disease or prostate cancer, and where data transparency ensures equitable, research-informed care for all women. This Canada is possible. It's going to require courage from policymakers, funders, clinicians, employers, and from all of us here. Let this fall forum be more than reflection. Let it be a commitment to act, to collaborate, and to lead. The gaps are real, the gains are meaningful, and the path forward is becoming clearer. Thank you. And with that, I'm honored to introduce one of our keynote speakers, Dr. Alana Cattapan. Dr. Cattapan is an associate professor and Canada Research Chair in the Politics of Reproduction at the University of Waterloo. Her work examines how reproductive policy is made and how it shapes people's lives. She has studied egg donation, commercialization of reproductive tissues, the politics of IVF, and approaches to supporting perinatal women at risk of HIV and sexually transmitted infections. As director of the Politics of Reproduction Research Group at Waterloo, her research consistently reveals how governments, the marketplace, and society define and constrain reproductive health and autonomy. She has published in studies in political economy, the Canadian Medical Association Journal, and the Canadian Journal of Political Science, as well as the Journal of Medical Ethics. And she is the co-editor of Surrogacy in Canada, Critical Perspectives in Law and Policy, as well as Feminizing in Political Science. Her talk today examines how women have been historically and systematically defined in relation to their reproductive capacity as perpetually, potentially pregnant. This framing has profound implications for medical ethics, research, and health policy, and shapes everything from data systems and risk management to whose bodies are included or excluded from care and study. Please join me in welcoming Dr. Alana Cattapan.
I didn't do any of the work I should have done before we got here to check how to do the slides, so bear with me as I figure out how this works. Okay, here we go. That was easy. Easy, amazing. O'Brien Institute, right? I don't know how to go after that. What a concise and beautiful, thank you, Erin, for leading us into this day. I don't know if I have anything to add. Should we all go home now? So thank you so much for having me. It's a real honor to be here and to share this day with you. My name's Alana, and as you know from that very strong introduction, I'm a political scientist. I'm also a feminist scholar who works in the field of law, politics, and reproductive ethics. For those of you who may not be able to see me, I'm a pretty tall, palish white lady in my 40s with mid-length brown hair and kind of large glasses that you'd expect of an academic. I'm wearing a black dress, and there's a lot of images on my slide, so on all of the slides that you're going to see. So if you're a person who might benefit from being able to interact with those slides in a different way, make them big on a phone or a device that you have, the project website is Perpetually, Potentially Pregnant. It's the title of the talk.com, and you can download the slides for today under the Presentation and Publications tab. They're right there. You can have them. They're yours. Okay, so the motivation for this project comes from the confluence of two events that occurred in February 2016. The first is that the World Health Organization declared that Zika virus was an international public health emergency, and the cause of concern was a link between the Zika virus and microencephaly, which governments and international public health organizations were quite concerned about, meaning that they issued travel advisories for the regions that were affected and suggested that while everyone should take precautions to avoid infection, that there should be particular attention paid to potential infection by pregnant women and women of childbearing age. There's one of those advisories. You saw this everywhere in airports at that time. 2 days after the WHO's declaration, the U.S. Centers for Disease Control issued a new report on women and alcohol. You might remember this one if you were around at the time. It got a lot of play. So the report suggested that sexually active women who stop using birth control should stop drinking alcohol completely, and further that all women should avoid drinking alcohol to avoid the risk of the following things, amongst others: injuries or violence, sexually transmitted diseases, or unintended pregnancy. Don't drink alcohol, it might get you pregnant. So the infographic that accompanied the report, part of which you're seeing on the screen, was widely, I'm a paper user and I don't have a lot of room on this podium, so let me get myself sorted in a different way so that I don't, there we go, let's do that. Okay. So part of what you're seeing on the screen, it was widely panned for failing to acknowledge the role of men, for example, in the so-called risks of alcohol consumption, with commentators drawing attention to the ways that women as a group were presented as would-be pregnant guardians of fetal health, but in particular the fetal health of people not yet conceived. So I'm focused on February 2016 because that's when this came into my consciousness. It's when I started thinking about the concept of women of childbearing age. But I could have been inspired by any number of events. And since then, every time I read the paper, every time I'm engaging with the news, I see the language of women of childbearing age or women of reproductive capacity or women of reproductive age making headlines. I see it in the concept in reports on studies about mental health, cannabis use, pelvic pain, labor force participation, rates of syphilis, and so on, often in ways that use the language of childbearing age as a proxy to talk about women in general, or to talk about the relationship between women and potential risks to fetal health. So, as I'll discuss in a few minutes, and over the course of the time of the rest of this talk, describing women in terms of their reproductive capacity is by no means a new phenomenon. It's been going on a long time. But it is clear to me in the research I've been doing here that there's been an increasing use of the term, these kinds of terms, women of reproductive age, women of childbearing age, I'll use them interchangeably, in biomedical research, in public health campaigns, and in the media. And with it, there's been increasing attention to the bodies and behaviors of women thought to be potentially pregnant. Okay, so look, on the one hand, there's a reason we use this language. There's a legitimate need to recognize women of childbearing age as a group because it's sometimes important to describe the capacity of some women, of many women, to become pregnant in terms of fetal and maternal health. We need to know about the outcomes related to intergenerational health and the impacts that pregnancy, exposures to chemicals, that kinds of thing, will have on fetal health, also on the health of future generations. The idea of women having healthy women having healthy babies is, on its surface, I think, a relatively innocuous one. It's something we can all get behind. But by making a distinction between women writ large also and women who might be or become pregnant, women of childbearing age is also a really useful way for biomedical researchers and public health researchers and agencies to distinguish between women as a group sometimes and women as people who may be gestating pregnancies. But on the other hand, the recognition of women of childbearing age as a population on whom such interventions should occur has, I think, some troublesome consequences for how we think about who women are, their health, and their role in society. And I'm going to talk about 3 concerns today. So I'm going to just outline them real briefly here. We'll come back to them in a little while. So first, I think that the ongoing and ubiquitous use of the term women of childbearing age centers women as responsible for the health of future generations while erasing the critical roles that governments, men, and industry have in fetal health. The individual behaviors of women are made to be the sites of potential health interventions and potential blame for the health or lack thereof of future children and future generations. It puts the blame solely and squarely on women's shoulders. Secondly, no matter how innocuous, I think describing people in terms of childbearing age primes us to think about women as a group in terms of potential reproductive outcomes, especially when we use this term uncritically and expansively all of the time. Again, I'm not opposed to the use of the term or the concept, but the way that it's been taken up and just used it all of the time everywhere without thought. So I think that this works to privilege reproductive aspects of women's health and to obscure all other elements of their bodies and well-being, siloing reproductive health from the other aspects of women's health. Okay, and third, and this is deeply connected to my other points, I'm concerned about the way that the uncritical use of this term may be shoring up commitments to the anti-abortion notion of fetal personhood. To put it simply, scrutiny of women's pre-pregnancy behaviors and focus on women's bodies and the reproductive capacity that this concept of women of reproductive age enables, I think may one day work to criminalize or otherwise punish some women, maybe not in Canada, maybe in some other jurisdictions, for not prioritizing fetal health prior to conception. So in the short time we have together today, I'm going to talk about the emergence of and use of the concept of women of reproductive age or childbearing age as a group on which public policy can be enacted. I'm going to argue quite simply that although the concept seems relatively benign, its widespread and uncritical use has important consequences for women's inclusion in society, for women's health, and women's reproductive autonomy. So we've sorted this little bit of an introduction. I'm going to tell you a little bit more about the context in which I have been looking at and thinking about this term, these terms, what I've found in the research. And I'm also going to, I'll go back to that agenda. And I'll also talk you through those 3 concerns in a more substantive way, and then I'll wrap up so we can chat about this. I'm a social scientist. I like to talk about language and I like to talk about people, but I recognize that there's a lot of healthcare providers and other kinds of researchers in the room, and I'm really excited about the conversation we'll have, so I'm going to try to leave a lot of time for that chat. So a quick note about the images that you're seeing. One of the broad goals of this project is to disrupt thinking about women's health as necessarily and inherently reproductive. So the images you're seeing today are from an artist, Jean Dibble. She's an emeritus professor at Notre Dame. And she provided these images for me to use in this project from one of her own projects, one of her series. It's called First Paradigm. And I just want to give you a bit of the artist statement, which is that First Paradigm superimposes images from obstetrics and gynecological textbooks over photos of women just living their lives to demonstrate how women are thought of first and foremost as reproductive. She thought it was apt, and I do too, and so I'm really happy to share her work with you today. Okay, and for those of you who are committed academics, I want to say also that there are methods to this project. The research I'm sharing with you today is part of a broader project on the concept of women of childbearing age and specifically how it's evolved in guidelines related to biomedical research ethics and public health campaigns in Canada. The work involves a four-part methodology where we've done a really extensive literature review, a document analysis of 2 sets of guidelines related to what's called preconception care, and also 2 sets of guidelines about inclusion of women in medical research ethics, and then archival documents related to those documents, and then interviews that are about those as well. And so there's a whole corpus of stuff that I'm drawing from here that I'm really not going to talk about too much, but it does exist. Okay, so about the context here. To be sure, I want to start by saying that even the idea, the language, the words women of reproductive age or childbearing age should be contested from the outset. So the WHO defines childbearing age as between 15 and 49. That was 15 to 44 for a long time, but it was changed a little while ago. But I also come across documents from other agencies and other places that use different numbers, even broader range. So girls as young as 10, and women as old as 55. But because I like to poke the bear here, I can imagine an even broader range. There's ovarian tissue freezing techniques for the fertility preservation of children, pediatric cancer patients that have been and continue to be used on quite young children, babies. And so the youngest child I know of who's had ovarian tissue extracted for this purpose was 3.5 months old. And if we wanted to make the argument without involving technology, we can think of cases of early onset puberty coupled with sexual abuse that make the case that pregnancy occurs in very young girls as young as 6 or 7. On the other end of the spectrum, in 2019, various news outlets reported that a 73-year-old woman in India gave birth to twins conceived using her own gametes, I believe, using in vitro fertilization. So if age is what is in question, what does it mean to be of reproductive age? Women can be presumed to be of childbearing age for most of their lives, from infants to retirees in the cases that I've mentioned. And despite differences in sexual activity and orientation, infertility and desires to have or not have children, again, what is the age we're talking about? There's no one way to define what reproductive age means, especially in an age of reproductive technologies. I have so many other examples on that. I do a lot of research around infertility treatment and how long you can store an embryo. Like, we don't even know. They can be in the freezer for 40 or 50 years. What is reproductive age is the question. Age isn't the only problem if I'm trying to come up with a definition here. Women of childbearing age aren't necessarily fertile or people who are engaging in the kinds of behaviors that might lead to a pregnancy. People who are celibate, who do not engage in heterosexual intercourse, who don't have reproductive organs that allow them to produce in conventional terms, or who are otherwise not at risk of becoming pregnant, do they count in the idea of women of reproductive age? Should they be counted? And what about the concept of women? What and who should we include when we define this concept? Thinking about historic inclusions and exclusions of trans and gender non-binary people in research and the forced sterilization and coercion of those people, like, what does that mean in terms of who we think of as potentially reproductive? And the history of the term is no less complicated. One of the things we did when I started this project was my research assistants and I tried to find the earliest instances we could of the term women of childbearing age, women of reproductive age in the literature. But it turns out, and of course this didn't occur to us when we were writing the grant, and it immediately appeared afterwards, women and women of reproductive age were used interchangeably throughout history. And so the concept often just referred to women of reproductive age in a specific way, but just using the language of women. I'll give you an example in a minute. In other words, and to put it simply, in many cases, the idea of womanhood is bound up with the idea of reproduction in ways that can't be unraveled. Okay, this history is like diverse and messy, and it changes across cultures, but I like to go back to the ancient Greeks here, because they include Plutarch's oft-cited dictate to the ancient Spartans for women to exercise, this is a quote, exercise themselves with wrestling, running, and casting the dart so that the fruit that they conceived might take firmer root and find better growth. Also, there are cautions in early modern Europe against being too fat or too thin or too manly or domineering or overtly sexual because it causes infertility. So everything from women's diet to fashion to exercise regime has been cited in different times and places and cultures as a source of concern about future potential fertility, requiring women as a group to continuously think about every aspect of their lives in terms of the effects on future offspring, with blame for any unintended consequences Any unintended outcomes, read infertility, most often ascribed to the choices of the individual. But as I've been researching this term, trying to find a place to hang my hat to define women of childbearing age or how it emerges in the literature, I can see the systematic use of this language in 3 places in the Canadian context that begin to explain how this population came to be seen as a site for policy intervention. What we say in public policy studies as a target population. I know public health uses that language as well sometimes. So the first is in the modern census. In the context of what we currently call Canada, the first known census occurred in 1666. You can really see my political science here. And while it included data about gender and age, there aren't a lot of documents that connect that gender and age to the concept of infertility, or fertility. But following the Confederation of Canada in 1867 and the establishment of a national census, there is explicit language in that first census, which occurs in 1891, that explicitly describes this population of women and defines women of childbearing age as women who are between 15 and 45 and counts them. Our searches reveal that this kind of language was starting to be used in other jurisdictions as well, explicitly in contemporary, like modern censuses, in the late 19th and early 20th century. Governments didn't just count women, but they counted women of reproductive age as a distinct group. And this seems to be particularly the case in censuses where there was a preoccupation on the part of the government with population growth. Nations and states are built of babies, they say, and governments are very notoriously interested in the fertility rates of their population. The second place where we start to see this language is in biomedical research ethics. I'll spare you the longer history because I know a lot of you are in public health, but a series of high-profile tragedies in the mid-20th century increased awareness about the permeability of the placental barrier, revealing in no uncertain terms that women, quote, needed to become guardians of fetal health, that the placenta is not. So to quickly summarize, chief among these was thalidomide, a sedative and sleeping pill that was prescribed in the 1950s and 1960s, which was marketed as safe to use during pregnancy and prescribed off-label as a treatment for morning sickness. This drug caused thousands of birth anomalies among the children of women who took the drug in the early stages of pregnancies. And another example is DES, a synthetic estrogen prescribed to pregnant women between the 1940s and 1960s with the intent of preventing miscarriages. And evidence emerged a few decades later that not only were people who were exposed to DES in utero, so not the people who took it, but the children that they were pregnant with, that they were adversely affected by the exposures, so too were their children. So the woman who took DES, her child and grandchildren would be affected by those exposures. So these tragedies led to significant concern about women's exposures to pharmaceuticals and how trials were occurring, leading to the increased regulation of medical research. This occurred in the United States first, but in Canada, this included the first iteration of federal research ethics guidelines for medical research, which if you're really interested in finding it, it's report number 6 of the Medical Research Council of Canada, which is now CIHR, which was issued in 1978. Report number 6 states that not only must research involving pregnant women include an evaluation of the risk and benefit to both the fetus and for the mother, but further, and I think this is important, that, quote, due to the possibility of unrecognized pregnancy, possible dangers to a fetus should be considered in any research that requires female subjects of childbearing capacity. And so it followed that due to the precautionary principle vis-a-vis fetal health, women came to be often excluded from clinical trials because if there's a plausible risk that harm, it was deemed, should be avoided, not just mitigated. Okay, and the third area where I'm seeing some of this work, or some of this language, is in pre-pregnancy care, in public health. And I'll offer here 2 examples that really oversimplify a much more complex and robust history. So the first is that in the early 20th century, research on both syphilis and rubella demonstrated critical links between maternal infection and congenital anomalies. So there was public outcry about the need to intervene to minimize the risks of infection, and it led to provincially mandated premarital blood tests in the case of syphilis and widespread vaccination in the case of rubella. And these were targeted campaigns that focused on prepubertal girls and women of childbearing age once the vaccine was available in that case. So intervening on women of childbearing age here was seen as a really important site of intervention for the future health of any children that those people conceived. But it's a really important moment where we see women of childbearing age, and girls in particular, seen as a site for the protection of future fetal health. I think this is an early precursor to what we have come since the 1980s, although it really took root in the 1990s and is expanding still, to call preconception or pre-pregnancy care. This is a way of addressing future fetal health by focusing on the behaviors of pre-pregnant women. And conventionally, preconception care interventions have focused on health promotion. It's a very long list. I'll give you some of them. So advocating for women to stay active, to avoid alcohol and drugs, to take folic acid, to stay away from certain chemicals, to receive treatment for STIs if necessary, to avoid medications that might cause birth anomalies, to lose weight, to update immunizations, to engage in good oral hygiene, and I could go on and on and on, but I'll come back to that in a minute. So again, while I don't think that there's a satisfying history about how this concept of women of childbearing or reproductive age emerged, I do think that these are moments where governments in particular have become preoccupied with the behaviors of this population, counting, creating guidelines, or prescribing behaviors to establish them as a group, again, a target population for public policy. So as I mentioned in the introduction, beyond the vague nature of this concept and its impossibility, of course it's gonna fall, that's okay. Here we are. I have some concerns about the reliance on the idea of childbearing age as a proxy to describe women as a group or stand in for women who might possibly be pregnant. So I'm gonna talk you through those three concerns just a little bit more. So that first concern I articulated before, about the continued use of women of childbearing age that centers and recenters the role of women as the primary and singular guardians of the health of future generations. First concern, okay. So in the paper I'm writing about this, in the broader project, I use the concept of maternal responsibilization as a theoretical framework, by which I mean the way we have come to make mothers responsible for all kinds of tasks and issues that might have historically fallen to someone else, or that we just weren't worried about before. So this applies to pregnant women who are made to feel responsible for the health of their children and meant to intercede in what feel like an impossible number of ways to protect their future child. So not only trying to have a generally healthy pregnancy and stay well, go to prenatal checkups, but also mitigating risk by spending the money and time, for example, to go organic or go to prenatal yoga or undergo genetic testing. And if you don't do those things, to feel like you've either failed to protect your baby if the outcomes are not great. For our purposes today, I'm concerned with how that concept of maternal responsibilization gets read backwards onto the bodies of people who are not pregnant and who are simply of, quote, childbearing age, who don't have children and may never have children. I'm interested here in how pressures for caring for your body in case of a future potential pregnancy are framed as preconception care. That is, that very long list of potential pre-pregnancy interventions that I mentioned before. Having good oral hygiene is having good oral hygiene. That's good for you. It doesn't matter if you have a baby. You should probably still brush your teeth. So that long list being framed again and again as in the interest of a future potential child, I think is something we should pay attention to. And what I've noticed, and what my team has noticed, is that scope of preconception care has just expanded tremendously over time. It's become, that long list that I read, has become longer and longer, when previously that wasn't the case. So I mentioned the research we were doing, the investigation part of the documents for this research. So we've been looking at the evolution of Canadian preconception care guidelines, which have evolved over the course of many decades, I think starting in the 60s until quite recently. The guidelines, the paper, not the computer. We'll get there. I feel like this pile of papers is a metaphor for me today, you know? Okay, so it started as a document for physicians and other care providers to help their patients understand how to think about approaching a healthy pregnancy. But as time went on, both of the sets of preconception care guidelines that we've looked at from the 1970s, 60s, 70s till now, we see a shift in how preconception care is presented. One iteration of the guidelines we're examining included just a few pages about preconception care in the 70s and one extra page in 1987 focused on what doctors should tell their patients about trying to stay healthy, things like avoiding smoking, eating well, trying to stay cool. Don't stress too much during your pregnancy, please. By 2017, that same chapter had blown up to 52 pages and tries to cover every possible risk, from flossing teeth to avoiding environmental hazards, to finding out your genetic history, to avoiding intimate partner violence, and so on and so on. And rather than speaking to clinicians or healthcare providers more broadly, or to public health agencies, these guidelines speak directly to women of childbearing age as their primary audience. There's a clear shift in the responsibility to engage in healthy practices to ensure a healthy conception and birth and pregnancy from the physician to the family, with the burden placed squarely, again, on women's shoulders, even when the possibility to avoid certain risks, like I'm thinking of some of the stuff about air quality, for example. How do you control the air quality? You can try. It's a pretty hard task. Or avoiding chemical exposures, when they're not likely to be in her control, or if they are in her control, they also could be in the control of government, of industry, and of other folks. I think that essayist Rebecca Solnit sums up this point best, perhaps more harshly than I might, when in her 2016 essay, The Case of the Missing Perpetrator, she argues that calls to address fetal health blame women for what should be a broader social responsibility. Speaking about the CDC report that I mentioned before on alcohol, she writes, quote, "I wish that all this telling women that alcohol is dangerous was a manifestation of a country that loves babies so much. It's all over lead contamination from New Orleans to Baltimore to Flint, and the lousy nitrate-contaminated water of Iowa, and carcinogenic pesticides, and the links between sugary junk food and a host of health conditions, and the need for universal access to healthcare and daycare and good and adequate food." That sentence, every time I read it, it's very difficult. Long breath, okay. It's not. It's just about hating on women. I don't know that we're in entirely the same predicament as Solnit's describing, but I do see that this focus on women as the arbiters of fetal health and as it being women's social responsibility isn't not about hating on women. Okay. My second concern is that this emphasis on women of reproductive age works to prioritize reproductive health care above other aspects of women's health and well-being. It constructs women as a group as first and foremost reproductive subjects, articulating that we're not really thinking about women or young women or middle-aged women, but women of reproductive age, putting reproductive capacity front and center. This emphasis that the language puts on women as reproductive subjects rather than as people or as patients is reflected in a long history of medicine that has not always taken women's health seriously or cared much about the outcomes for women as a group. So as I said before, part of this broad project looks at how research ethics guidelines have taken up the idea of women of childbearing age as in terms of inclusion in medical research. So women were historically excluded from clinical trials, and particularly in the wake of the experiences I described related to DES and thalidomide, which required research to consider possible dangers to the fetus in any research on women of childbearing capacity. So this translates to, in many cases, the whole-scale exclusion of women from trials in a range of areas, perhaps the best well-known of which is cardiovascular research, although there are many, as Dr. Brennand described before. The reasons for this, that there might be risks to fetal health, are one of a number of reasons that women have been excluded from clinical trials. There are lots of unsatisfactory reasons that have been used, because women's hormones and menstrual cycles are presumed to be difficult to control and to find out baselines, or because women of childbearing age can never guarantee that they're not pregnant. And if somebody says to me again, what if they're raped, I will throw them down the stairs perhaps. I don't know, that's my... I threaten violence on a podium, that's a great move. Okay, so, but because of women of childbearing age couldn't guarantee that they wouldn't become pregnant, even if they were using multiple forms of birth control, not having heterosexual intercourse, or if they were celibate or infertile. Commitments to considering risks on the fetus have meant that women have only been seen as potentially pregnant research subjects, not as critical populations that must be included in clinical trials. Medical researchers, feminist medical researchers, despite a lot of work to ensure inclusion of women in trials, are still struggling with the consequences of these research gaps over time and examining how women react to standard lines of treatment that were developed around men's bodies. And the emphasis on women as reproductive subjects rather than as patients in their own right has also caused a squeezing out of non-reproductive aspects of women's health in medical care. I think reproductive health care is underfunded, is underdeveloped, but we don't know a lot about other aspects of women's health, because when we are focused on women's health, it tends to be reproductive because it tends to prioritize fetal health. So when you ask women in their 20s and 30s about those preconception care guidelines, they're meant to ask their doctor about a list of issues so long that it would take a doctor all day to address. So in contexts like the Canadian context, where medical appointments are time limited and where access to a clinician might be strained, people are forced to prioritize which medical issue they're going to bring forward. And that might mean asking questions about your potential future fertility when you might have migraines or other aspects of your health that you need to be addressed. I just list my own ailments. Let's just talk about migraines real quick. Okay. Ultimately, my point here is that by talking about women as a group in reproductive terms, we reiterate that our bodies are first and foremost a matter of reproduction and minimize the utility and functionality of our bodies in other possible terms that would allow us to see women as more fulsome people and as patients outside of the reproductive silo. We're all of the things. Okay, last concern. I'll be quick on this one. The third concern is that in some ways, the uptake of women of childbearing age as a concept and the ways that it brings reproductive health to the fore and makes women responsible for the health of future generation quietly legitimates fetal rights discourse by pushing women as patients out of the discussion. Again, I'm going to spend less time here. I think it's quite related to the other points. I think you can sort of follow the logic, but I do want to flag it for you here because I think it's important in the contemporary context. The most direct way I can say this is that one of the things that I pay attention to in my research is the criminalization of pregnancy. Some of this has included work on the criminalization of pregnant people who use illicit substances, by which I mean drugs. And a lot of this work centers around arrests and new approaches to criminalization in the United States, where women who use illicit substances have been charged, arrested, sometimes they're confined in the name of protecting women from causing harm to the fetus that she herself is carrying. So we need to confine you so that you won't harm yourself. By yourself, we mean the fetus. We don't care about you. Okay, there have also been cases where women have been charged following a miscarriage or stillbirth for not pursuing prenatal care, with some attempts to expand definitions of child abuse and neglect to blame women for pregnancy loss seen to be neglect because she did not pursue certain kinds of prenatal interventions. She herself is framed as a potential source of harm and neglect for not doing things to her own body. So what does this have to do with the concept of women of reproductive age? And I want to say I'm not so concerned about the Canadian case. I realize I'm speaking in Alberta today, which is a little bit different given your current political climate, but I'm a little bit worried about Alberta. Okay. Our courts and legislatures have been clear that the state should not intervene on women's bodies and on the bodies of pregnant people without their consent. And, for decades, we have really not had the kind of cases that we see elsewhere. But what I'm paying attention to, what I'm tracking, what I'm noticing elsewhere, and what I'm sniffing around for here, really paying attention to the context of the United States, is increasing knowledge and awareness and pressure on women about what to do in the prenatal period, eat organic, do yoga, etc. The more we pay attention to what is good for a baby prior to conception and put that pressure on women, I'm genuinely concerned that there may be ways that harms to children are traced back to the behaviors of pregnant people, not just in the prenatal period, which is incredibly problematic on its own, but also in the time prior to conception. If the harm happens to a fetus of a woman who did not engage in risk mitigation prior to the pre-pregnancy period, who was using drugs at that time, prior to conception, may they one day be found guilty of fetal harm? The question I'm thinking about here is that if we're talking about the ongoing and continued expansion of what constitutes potential fetal harm, and I've been paying attention to the case in Arizona where embryos were recognized as people, as would-be babies, how far back in time does perceived responsibility for fetal health go? Okay. So I've been talking about the idea of reproductive or childbearing age. You're going to start noticing it everywhere. I'm excited for you. You're going to hear it in the news. You're going to see it in your papers. You're going to notice it. And my goal here, all of this, is for you as public health professionals, as researchers, as students, as healthcare providers, people designing studies, that you notice it and that you think a little bit more about the work that the language and concept is doing. And I don't mean to suggest, again, I've said this a few times, that you shouldn't use this term at all. But I think it's important in studies where reproductive health is being examined and where we're legitimately interested in effects on future generations. There is meaningful and important use of the concept of reproductive age. It does mean something, especially in fertility care. But ultimately, words matter. They tell us what we prioritize and what they shape what approach we take to ideas, what we fund, and what we resource. The prevalence of the idea of women of reproductive age can and should give us pause in particular because its emergence over time has occurred along with these other trends. Increased maternal responsibilization, the ongoing failure to substantively address non-reproductive health or to address reproductive and non-reproductive health cohesively, and the surveillance and criminalization of pregnancy. So the point I want to make here is that pay attention to these terms and the political power that they hold. Thank you. Are we supposed to sit? Okay.
Yeah, we get to
don't
sit
know.
down as our Q&A.
Well, I'll sit in the mess I've created. Okay.
All right.
One more slide. You don't need to look at that. Okay. There. Of course, these mics are already on. You guys are so good.
All right, I'm going to start with the questions. You've shown how potential pregnancy thinking still influences our data collection, the concept of risk management, and even policy design today. What do you think, from a public health and policy perspective, that it would take to move beyond that current paradigm and to build systems that see women as whole people rather than perpetual potential mothers or a vessel for a fetus?
Sorry. Is the question, like, why hasn't feminism dealt with this already? Like because I think if we go back to that Rebecca Solnit quote, if this is ultimately about the, like, deep-rooted manifestation of misogyny and the legacy of deep-rooted misogyny in our culture, you know, I think your talk really spoke to why don't we pay for these things? Why don't we prioritize these things? Why haven't we addressed that what is the stat? 1 in 5 women will experience PCOS?
1 in 5, yeah.
That's, like, on paper, in reality, like, just absurd, right? But it's not absurd in the context of a society that has not historically thought of women as people. Like, is that too blunt and straightforward an answer? I don't think Solnit's wrong.
I don't think so either. For me, one of the questions is...
Your question was what would it take?
Yeah,
like,
what would it take?
Any ideas, you guys? Like, maybe we can solve this together.
One thing that jumped out at me as something that I don't hear often enough is calling out male and men's responsibility in the health of female and women's health here in Canada. Do you have any thoughts on how that idea can be advanced and can catch not only among women, but among men, because they do have more power?
Sure. I think that the responsibility for fetal health not falling to men or not being articulated as falling to men is also a major fault of misogyny, of toxic masculinity over time, and also of just not really a great deal of attention paid to the field of andrology. It's a really underdeveloped field. The researchers who work in urology and andrology will tell you so, that we didn't really understand how sperm were moving about for quite a while. And that really the expansion of that field and understanding of what sperm do, their contributions to reproductive health, effects of toxic exposures on the health of semen, is really, like, quite emergent. It's not as, like, gynecology is very well developed in relation to andrology. So we really just don't know that much because we've tasked women and women's bodies with being responsible. So I think greater investment in that as well, if we're to understand infertility and fertility tracking, I think that that's quite important. And I think like men should be advocating for this. But you will see a lot of headlines, again, when you're paying attention to this, when you notice this language now, you might see men of reproductive age occasionally, and usually it's about high rates of male infertility, or like there's always like the sky is falling, decline in sperm health kind of headlines that appear. Like it's like every 5 years in the New York Times, they'll tell us that the species is doomed, men don't have any sperm left. We'll be fine, it's okay.
I'm going to ask a question here. They're starting to populate through the Slido faster than I can read. I think maybe I need reading glasses. For people working in the world of preconception care, even if they frame interventions such as good for you too, like the brushing the teeth analogy, there are things that are specifically only for baby. So the example that's given about folic acid, the benefit is for the fetus, and there is some questionable data about risks that female people take when taking high-dose folic acid for later in life, such as your risk of cancer development. So how do we frame that conversation in a way that is safe and not stigmatizing?
So I think we just need to be honest about what we're doing with folic acid, for example. So folic acid doesn't necessarily benefit the fetus until there is any conceptus, any embryo that has occurred. But the idea is that if you take folic acid prior to pregnancy, that will affect your fetus. That you don't need to take it 6 weeks in advance, especially people going through things like IVF, when you know when that pregnancy is about to occur, that's when you can start taking folic acid. But we articulate this as a preconception intervention because we don't trust women to know when they might becoming pregnant, and we presume that unintended pregnancies or unplanned pregnancies we say that it's about 50% of pregnancies, but the data shows quite clearly that it's not always people who are not planning at all. They're people who may have stopped, may have stopped worrying about it so much and the pregnancy occurred. And so informing people about when you really need to take folic acid is one example here. Is it a preconception intervention that will actually affect the fetus if you do it well in advance? No, and it might have adverse consequences for you. So being quite clear and honest with people, and I know public health agencies and scholars have a lot, like you're balancing the idea of how to really get these ideas in people's heads in a way that will stick, will be effective, that they won't get confused about. You're speaking to large swaths of people. But I was like quite surprised when I was doing this research, trying to get pregnant myself, and realizing that so many of the things that I was being told that would be helpful for my fetus would not be helpful until conception had occurred.
There's two questions. I'm going to try and jam them together.
Oh, fine.
They're about terminology. And so one of the questions is about, I think, the vagueness of women's health and whether we should be more specific in calling it reproductive health. And also the thoughts on the phrase, and I really hate this phrase,
Yes, please.
bikini medicine.
I
really hate the phrase bikini medicine, which implies that women's health is constrained to what fits under our bikinis, so our breasts, our reproductive organs.
Do you want to answer that question?
I mean, really, I think I've answered that. I think bikini medicine, I've heard people try and use it in a way that is derogatory towards the work that I do clinically and the research that I do, but I've also heard people try and use it, maybe not in a supportive way, but to say that women's health is more than bikini medicine. It still gets me very upset because it is a reductionist approach.
Mm-hmm. Yeah, I don't like it either.
Let's not use it. Let's all commit to banning that word, those two words.
Well, I just think about an equivalent situation in male reproductive health. That's not going to come up. You know what I mean? It's incredibly reductionist and attempts to put people on the defensive right away, I think. Yeah.
And then I think the word women's health, I don't think we have the answers between the two of us, but I think it's to acknowledge in some ways it's too broad. It, for me, I think also allows a lot of siloing of core healthcare concepts to say that it is a women's issue, and so the people with power don't see investment. So an example is bone health and osteoporosis. So that's a woman's issue. It may not be a priority in bone and joint research if it's perceived as only affecting us, and that leaves, I think, vulnerabilities for males who experience osteoporosis and do and can if they're not part of interventions and health campaigns to keep themselves healthy through aging.
Yeah, I think the broader concept of women's health is tricky because on the one hand, you were quite careful in your remarks to say women's reproductive health, that you were talking about gaps in women's reproductive health and that is one area of medicine. But women's health more broadly is like everything. It's your whole body. It's all of the things. As well as we try to like loop in fetal maternal health inside of that. And so it's such an overbroad concept. At the same time, it might hold political power. Like you all attended today with this women's health is public health on the agenda, recognizing that it would likely be about both reproductive and non-reproductive aspects of health. And I say this a lot in relation to my own field, political science, where women have been coming to prominence, but we're coming up against the same kinds of barriers historically that have kept women out of sort of the halls of power and in decision making, out of the journals, all of the things. But I say to my colleagues often to like take solace, I guess, in the fact that we are starting to outnumber them. We are political science, like it's us. We can just take over the journal. We could just do it. We can just change all the rules. Like, so as you are the leaders in public health in your organizations, of people putting on this conference and panel, thank you again so much for having me. Like we too exert power. And I think like we are burdened with the task of questioning the status quo all of the time. When we come up against, funding proposals that ask us to check off women's health to say maybe as a funding priority, but maybe to be hived off, right? To not be prioritized in the funding proposals at CIHR, that maybe they want to put you under one underfunded institute instead of more broadly, to push back, to become part of those institutes, to say again and again that we will not be ignored.
I think that sort of leads into one of the questions. Oh, me and Slido are not having a fun time. It was a question about, like, what is the strategy for us, like the public population, half of the population, to get the funding and really the power that we need? I think the idea of being present, of taking over, I love that idea. But if speaking to people who presently hold the power isn't enough, I'm sure that there's a lot of us in the room who feel like they've been speaking to deaf ears for years. Mm-hmm. Do you have any thoughts based on other movements that have caught the attention, got the resources and the momentum they need? What do you think has worked well?
I don't think it has, right? Like, Solnit's wrong, we're not wrong. That like misogyny is a critical factor underlying all aspects of our society. And the more that I like live and exist as a feminist researcher, it's in every field, all of the time, always, every meeting, everything, all of the time. Like the introductory remarks, like notice that you could have it, like we welcome a baby in the room. Like that should be normal. You should have your baby everywhere. It's fine. They're babies. Like we were all babies. It's cool. That isn't normalized yet. That's absurd to me. Or that there are circumstances in which you wouldn't be able to move around, that accessibility is still novel for folks. Like we are up against a system that is changing at a glacial pace. And so I don't think that there are good examples of how things have completely turned over. But I will say that the research on parliaments, for example, like the research on health systems, show that a critical mass of women, whether or not they agree on the topics at hand, really can make a difference, as can just ongoing feminist and women's leadership in the halls of power. So I don't have any answer. Like the question is as unfair as the first one. How do we fix this? I don't know.
I think one of the things, I don't know if it's not a full solution, but one of the things I've noticed with respect to advocating for women and female health is the expectations that it be led by women and that women need to be nice, right? We can't advocate in the same way that men do. Our tone and our language is expected to be nice, and then you can shuffle us off into the corner. And so I think in 2025, the conversation needs to perhaps have a different tone. Women need to, rather than suggest and ask, I think we need to start to demand.
Yeah, it's sort of a few things
More.
at once, because like, this is like, I feel like we're having the conversation that every feminist conference ends up having, or, the classrooms that I operate in. So on the one hand, is it the responsibility of women to lead the charge here? Should it not be the responsibility of everybody? And yes, like as we see with people of color, with Indigenous folks, when you want change related to a population, at once, like in some sense, you do want the leadership of those groups to be well represented. On the other hand, that is a tremendous burden to put on the folks in question. But women are a very significant portion of the population, majority of the population for the most part. And so I don't think that burden sits as heavily here. In terms of tone, there's sort of two things happening at once. We can have conferences and meetings that are inclusive and lovely and engage with a kind tone and speak in a way that has become and is really lovely. I'm enjoying this. This is great. But also something a mentor of mine told me really early on was like, why do you care that they called you a bitch? Like, why do you think that bitches aren't cool? You're amongst the most powerful people when they do that. So use the tone, yell at them, demand all the things. Why do you care what they think? So I do care. I try not to care. I think I've been socialized to care. But I really, when I want or need to make a strong position, take a strong position on something, I think of my very powerful mentor saying why do you care what they think?
So let us all leave here caring a little less when someone calls us a bitch.
Don't you think that comes a little bit with age, though? I don't know. I feel
does.
like the feminists who have come before, and I see this when I operate with women who are older than me, they have just come to care a little less, and I admire that. And so I too need to care a little less.
All right. So many good questions.
You have my email. You can just email me these. I'll email you back.
Because I won't get through them all.
It might take a minute. There are a lot of questions.
There are. So how can we combat feeling demoralized when we work in this space where every day ourselves as women, our fellow females and women, are historically and continually reduced to baby-making bodies?
Mm-hmm. Yeah, I'm going to sort of just take that question and go somewhere with it, I guess.
Yeah.
In the research that we've been doing on the preconception care guidelines, which are really well thought out, really well researched, people are trying to do a really good job to get information to folks, but that information is overwhelming. Something that's happened in maternity care over the last 40 years or so is a shift to what's called family-centered maternity care. But when we look at, so that is meant to include moms, it's meant to include their family, it's meant to include sort of a broad spectrum of not just looking at either maternal or fetal health, but the collective together. But when we see maternity care in hospitals play out, we often see a excessive focus on breastfeeding, although breastfeeding is really critical and should be taught in the ways that many times it is. People feel a lot of pressure around that. They don't feel like their choices are listened to. They feel like the health of the fetus is prioritized. And I'll give you an example that my neighbors have been talking about all week because somebody just gave birth on our street. Is that she was in the hospital and they kept calling her baby by the name that they had chosen, and they kept calling her mom. It was driving her nuts. She was like, my name is on all of your charts. You see it all of the time. Just could you call me by my, I know that I am a mom. I was a mom before, but when I wrote my name down, I didn't write mom. And so the engagement still focuses on, at least in that case, and in other cases that we look at, the fetus as the primary source or primary site of intervention, and not on the sort of group as a whole or on what women want as caretakers or as mothers.
That's really powerful. I'm pretty sure quite a few of us in this room have had the experience of, on the postpartum unit, being referred to as mom every day until
I will
discharge.
say that the gynecologist referred to her by her name. She was so glad to see her gynecologist, but everyone else.
I'm delighted to hear that. We are doing a little better then. One suggestion, more of a, I think, a question or an open opening is that perhaps primary care providers can normalize educating male patients to come in for assessment and education or assessment of readiness in the preconception period. Would that fit with the family-centered model?
Yeah, if they're planning on using their own sperm, I think that it's useful. A lot of the interventions that relate to male reproductive health actually go back quite further. So exposure to example, and I don't know, I feel like everything that I'm saying about medical research, someone's gonna be like, there's a new study. Like, you may know quite a bit more than I do. I'm only as good as the last time I looked it up. But there is a lot about male exposures to chemicals, to smoking, for example, that can affect people. It affects semen quality if you smoked as a teenager. And so we might be thinking, rather than education about smoking might affect your infertility or your fertility experience, how do we address rates of smoking even further amongst young men? Why focus on fertility when most of the interventions related to fertility and infertility are things that are good for people anyway? Like STI treatment, for example, that might cause infertility. You keep looking for more questions, and I could go on with examples forever. I'm really enjoying this conversation, though.
So am I. There was one that just slipped on by. Where did it go? It was great. It was about cervical cancer screening. Okay. This comment is about the fact that sometimes women's health is used to push more is better to increase business. The example they're giving, I can almost guess who put this one out here, is that cervical cancer, cervical cancer screening, as we know in my lifetime, changed from an annual test to every 3 years. And there was pushback from gynecologists and reproductive health care specialists that this was a scary change, and that I think in some ways it took, whether it was power or our own responsibility for people's health by making it every 3 years. I am going to admit I have some not fully parsed out feelings about the shift to at-home testing, but the concept of promoting women's health as resulting in more business. So frequency of cervical cancer screening, for me, when I think about promoting women's health and more business, I think of all the ads that I receive. Clearly the algorithm knows how old I am, telling me I need to join Maple or Felix, that I need to talk to somebody virtually and get my menopause addressed, that I must have ADHD. Am I feeling overwhelmed and my focus is pulled in my mid-40s? You must have undiagnosed ADHD. Join Felix, we'll give you some Vyvanse. So really, I think talking about how there is potential when we advocate for the health of females and women, that somebody is going to economically benefit from that or commercialize our stages of life. Any thoughts?
Any thoughts? Yeah, yes, absolutely. A lot of my research, and I think we're going to talk about this a little bit on the next panel, is in assisted reproduction and fertility care. And we see that a great deal in that field where, there is pressure put on women to be advocates of our own health, in part because we experience a lot of dismissal, or historically have experienced a lot of dismissal of our symptoms and pain. We know this to be true across populations of women. And so women becoming the consumers, coming to the doctor with, I need this, I'm gonna need this, I'm gonna need this. In the case of fertility care, you enter a clinic and it's quite challenging to wrap your head around all of the things. And there are moves to sell you all kinds of things that you may or may not need, presuming, relying on the idea that your doctor knows about what's best for you. In the case of cervical cancer screening, the presumption is here that the healthcare system that is also strained may know what's best for you. And so the move to every 3 years becomes a challenge for people who could benefit from more frequent screening, for example. I also think about, and tell me if this is a conspiracy theory because you work in this field, but it feels very strange that in a population of women who are moving out of their 30s and 40s or moving into their 30s and 40s, who were the population who were most likely to be exposed to HPV without vaccination, that it changed just as they would be aging out of their reproductive years, and that the population of people likely to get a vaccination would be coming up. And so I imagine that there's more relationships there than I'm aware of.
Yeah, I think that there's...
Sorry, I just opened a lot of things.
There's a lot of things to think about in terms of cervical cancer screening. I think that healthcare providers do believe that the interaction, the face-to-face interaction that comes from screening brings value and contact and relationships that promote health. There's a fear that, for me, that yes, people who have not been vaccinated, that the people most at risk of not being vaccinated may be the most at risk of not engaging with home screening. And perhaps it's a savior complex to believe that the old way of delivering screening tests and healthcare is somehow going to lead to a better outcome. Maybe we need to work through that as a profession. I have no idea, actually, if I influence people's care. So, and then also the tidal wave of misinformation that is preventing young girls and boys from getting the HPV vaccination now. In 2025, Alberta had set a target that we would have over 90% of our youth vaccinated for HPV, and we are falling behind, and nobody in this government seems to be holding themselves accountable to a promise that was made in the past. And there's lots of things that we could talk about. But now I have got a sign facing both of us that says our time is up. I think we could talk forever, you and I, Alana.
Thank you.
Thank you.